a comprehensive study of viable approaches for states interested in pursuing universal family care, paid family medical leave, and long-term care services and support policies. In other words, a universal family care program that were based on the findings of an Academy study panel made up of 30 interdisciplinary experts. The information in this report is more important than ever as the COVID-19 pandemic continues to highlight the inadequacy and inequality of our country's care infrastructure. A patchwork of programs does exist at the state and federal level to help low and middle income families pay the costs of early child care and education, long-term care services and supports, and taking time off to care for a loved one. But these programs are chronically underfunded, insufficient, and inaccessible to many, as most of you know in this room. The COVID-19 pandemic has laid bare in a dramatic way the challenge of balancing work, family, and health for workers across this country. And these challenges, we know, will be with us and will continue long after the current crisis subsides. As a model, universal family care offers an integrated, holistic, social insurance-based approach to family care that is designed to strengthen our care infrastructure to meet families' changing needs over time. However, it is not a universal panacea, and every community has a specific policy context and unique demographic challenges to address. And during this time of crisis, communities must be coming together to examine the gaps in the care infrastructure that exist and to explore bold policy approaches that increase quality and accessibility of care for individuals and families that need it. And that is exactly what we're here to do. So before we jump into the wonderful work of the panelists, let me just give you some housekeeping notes. So first, we want to apologize. We're not able to fully close caption today's live discussion. There will be closed captioning recordings of today's meetings available on the website later this week. And so we also welcome your suggestions for making future virtual meetings fully accessible to everyone. We encourage you to participate in today's dialogue using the tools on your screen. So there's two ways to participate. You can either type your comments in the chat box or use the Q&A box for specific questions for the speakers or for other participants to consider. Both the boxes are available at the bottom on the menu at the bottom of your screen of the Zoom bar. We also welcome questions via email after you've watched the closed captioned recording of the roundtable if you prefer to submit your comments that way. The chat feature will enable a conversation among audience members. So please make sure that when you use the chat, the recipients are all panelists and attendees. The default option is going to be all panelists, and so you're going to need to manually switch that. And this will ensure that all participants can see your comments. When the webinar ends, we hope to continue the conversation on the Academy's website. The caregiving research section of the website contains relevant work compiled by members and staff of the Academy, including the Universal Family Care Report that is the basis of this webinar. And so with that, I'm pleased to welcome and introduce our two speakers, Alexandra Bradley and Marc Cohen. Now, Alexandra Bradley is the lead policy analyst for the Caregiving Study Panel Project. For 3 years, she's worked with the National Academy of Social Insurance, conducting research and policy analysis on issues related to caregiving and health, including paid family and medical leave, long-term care services and long-term services and supports, Medicaid, and early child care and education. She also has many years of experience providing direct services and is currently managing the outreach program of a community-based harm reduction organization serving marginalized communities across Washington, D.C. Alexandra holds a Master of Public Health degree with a concentration in maternal and child health from George Washington University and bachelor's degrees in psychology and government from Cornell University. Marc Cohen, our second presenter, is the co-director of the LeadingAge LTSS Center at the University of Massachusetts, Boston, as well as a professor of gerontology there. He's also the research director at the Center for Consumer Engagement and Health Innovation at Community Catalyst. From 2018 to 2019, he served as the co-chair of the Academy study panel that issued the Designing Universal Family Care report. Over his 30-year career, Marc has conducted extensive research and analysis on a variety of public policy issues affecting the financing and delivery of long-term care services and has promoted public-private partnerships in helping to address the nation's challenges. He has testified before Congress and other organizations on issues related to long-term care financing and private insurance. Um, he has served on Governor Deval Patrick's task force on long-term care financing for the Commonwealth of Massachusetts. More recently, he has served on the steering committee for the Long-Term Care Financing Collaborative, which published its recommendation for improving the nation's financing for long-term care. And with that, I will turn it over to our first speaker, Alexandra. Take it away.
All right. Hello, everyone. Thank you so much for having me today. My name is Alexandra Bradley, and I'm really excited to be here talking about early childcare and education and also the paid family and medical leave portion of the Universal Family Care program. So you can take it to the next slide. My first reflection on universal family care is why the question we often get asked is why include early child care and education in a universal family care program. Both paid family and medical leave and long-term services and supports have kind of a history of some kind of social insurance-based funding in the United States and elsewhere, but early child care and education seems like it could be a bit of a curveball. It's not something the US has typically funded in a social insurance manner. But actually, early childcare and education is ripe for social insurance funding, making sure that our youngest children are provided a holistic education and well-being in their early years is actually preparing for the success of our future workforce, of our caregivers, of our communities more broadly. And early childcare and education is not treated on par with our current K through 12 education system, even though the earliest years under 5 are typically the most important for a child's development. We pay for our K through 12 education through tax revenue, through funding, but not often our system for children who are under 5 is very much a patchwork system. Only very, very low income families are eligible for most benefits, and the eligibility requirements are strict, confusing, and can make it very difficult for parents to access what they need in its fullest content. There's a high cost benefit value for families and for society as well. Next slide for me. So when we think about an early childcare and education program for a universal family care, what kind of goals are we trying to achieve? One of the most important ones is improving the quality of the care landscape. Right now, we have a very patchwork system, as I mentioned earlier, but there's a very high return on investment when we have a high quality early childcare system in place. We're also looking to ramp up the quality of the care provider workforce. This means improving things like compensation for early child care providers, improving access to training and workforce development for our early child care providers, and also improving equity and access to care for families. Right now, we see a lot of very unequal regional distribution, a lot of a lack of access to the care that families need, and a lot of high costs for those who don't qualify for the very sparse existing programs in place. So many families, while the Department of Health and Human Services kind of cites 7% as a reasonable amount that families should be paying for early child care and education, most two-parent families are looking at about 10%, and most single-parent families are looking at paying about 33% of their finances of their income per year to pay for early child care and education, which of course is completely unaffordable for the families with higher rates of risk. So we're looking at just efforts to lessen the gap, to place more priority on a child's early care and formal education. Next slide for me. So what were the policy options that we looked at when we talked about early child care and education? Well, the most generous, we look kind of at a spectrum between different options that might be more or less generous for families in need. So the most generous program, the one that would kind of be a gold standard in terms of making sure that everyone had equal access, would be a comprehensive universal program, akin to what we might see in other countries, especially in Europe, where all children are eligible, and it's an expansion of the existing public education system. So every child will be eligible for early child care and education. This is a high investment up front, but so is K through 12 education, and we've been doing that for a very, very long time because we saw the need and the benefit to society of making sure that our children are educated. So it wouldn't be that much different from our current system. It would just be pushing it back so the youngest children have access to the same thing as our older children. The second option was an employment-based contributory program. This would be designed to target working families, but coverage not being universal means we're going to see a lot of that continued stratification in who has access to benefits. It also means that administration on the state level would be challenging. People may slip in and out of eligibility depending on their connection to employment, which can also be highly volatile for the children and the families involved. And it brings up questions of whether or not children are going to lose access mid-year if their parent loses their employment. We don't want to see a reproduction of the existing healthcare system that is tied to employment. So those are some challenges with this. But some states may be interested in an employment-based model if their goal is to target specifically working families, or if they're not able to ramp up to a comprehensive universal program. And the final option, which is a little less generous than a comprehensive universal program, but still makes sure that all children are covered, would be a universal subsidy program. So it may or may not cover the full cost of care, but every family gets something to make sure that they can provide for their children to have early childcare and education. There's no guarantee that that something is going to be a sufficient amount. That would depend on the state's decision how much to give families. And the amount that families are going to need to pay for care, as we all know, is going to depend highly on geographic location, right? Because cost of care is different. Even if you're, say, for example, living in a big city, it may be more expensive to receive care, like here in Washington, D.C., than it is in a smaller area. But that depends. It depends on everywhere, a lot of factors. It does give greater flexibility for the state and for families. Families would have kind of more flexibility to choose what they want to do with the subsidy that they're given. But again, we have to do a cost benefit analysis of whether that is going to be a sufficient amount for the families that need it most. Next slide for me. And then some of the trade-offs, as I mentioned, programs that are universal are going to be better positioned to improve equity in child development outcomes. So when we're looking at when we see the best results for children who are at the margins, we're going to see a better outcome when all families are kind of lifted together and given the same access. Because right now we are seeing a patchwork of systems, and that's not been working. So something that's universal is going to be better positioned to improve outcomes. Programs that are employment-based leave many children out, and as I said, are inconsistent or unstable. Something that I think is important for states to think about when designing this program is making sure that private childcare providers are included. It's going to be very unlikely that a state's going to be able to go from 0 to 100 in terms of expanding a public education system. And so as they ramp up, even if they choose to do a universal comprehensive system, it's very likely that private childcare providers will need to continue to exist and fill in the gaps that a public system would not be able to pick up right away or ever. We also need to include factoring in making sure those childcare providers are given adequate compensation, are given adequate training, and are prepared for the task ahead of them, because it is going to be ramping up and evolving over time. We need to make sure that our workforce is cared for just as much as our children. And finally, the generosity of benefits, especially in a subsidy program, is going to make a meaningful difference for families and how they are able to interact with and access care. Inequality may actually increase under a subsidy system if the amount is so low that only high earners benefit and the lower earning parents are not able to actually access meaningful childcare supports. Next slide for me. Great. So the second program that we're talking about is paid family and medical leave. We actually have a lot to work with already in terms of paid family medical leave in the United States. There's a landscape of existing programs, and actually quite a few came in like dominoes when we were writing this report, which was very, very exciting. So 5 states have longstanding temporary disability insurance programs, which is the medical leave portion of paid family and medical leave. And 4 states added paid family leave on top of those existing TDI programs. But then also another 5 states since then have built completely new comprehensive paid family medical leave programs from scratch. They didn't have existing TDI programs in place, but they built something from the ground up and are in the process of implementing those right now. So some of the states actually haven't really gotten off the ground yet and are just beginning to be studied. So we'll have kind of more information as the years move forward, which design is better. or if there are pluses and minuses or trade-offs to different designs, but that's kind of the landscape that we have right now in the US. Next slide for me. So what are some of the decision points that we've learned, lessons learned from the paid family and medical leave programs that already exist? Well, there are certainly structural design factors. How the program is designed is going to affect how meaningful it is for families, what they have access to, and also who is responsible for managing different aspects. So it might actually make a very big difference who is administrating at the government level the program, and it's going to change the nature of how that program works out. Who pays for it and how are revenues collected? In most states, it's a shared pay between employers and employees. In some cases, actually in a lot of cases, there are employee-only revenue collections, so just the employee is taxed. In some cases, it's shared, more like Social Security. And then in one case, the District of Columbia, which is a bit of an enigma, it's the employer that's actually taxed exclusively, but that has to do with kind of some local home rule situations that are not really relevant to other states. And I wouldn't honestly recommend that process because it created a lot of challenges for the district in passing the law. Other decision points, qualifying events. Who counts as a family member? What is a trigger point for taking paid leave? In some states, we've seen kind of more strict who qualifies as a family member. It would be, you have to prove some kind of relationship to a family member. In other states, that may be more broad. It may include chosen family, which is very important for people with disabilities or people who are living without family or don't have spouses or things like that and who still need care. In other places, you have to have some kind of blood or legal tie to the person. So that's something that states have to consider. Also, how long do you have to have been working and what are your earnings requirements to be eligible for these benefits? And finally, a very important question is how much time can you actually take off to receive care? It varies widely between states, and in some cases, it even varies between what type of leave that you're taking. So in some states, you get more time if it's a personal medical leave. In some states, that means you get less. And that's going to affect people's ability to take meaningful time off for their care needs. And then finally, are you actually guaranteed your right to return to your job when you come back from leave? Is a very important, it seems like a minor point, but it's a very important factor that folks are not going to have to be afraid of losing their job if they take time off to provide or receive care. Next slide. And then so we had two kind of major policy options for paid leave. The contributory social insurance model is what we've seen in most states, almost all states, honestly, that have chosen a paid family and medical leave model so far. This really simplifies administration because it means that everybody is pooling all their money into one bucket, and then anybody who needs to take leave is taking it out of that bucket. It spreads the risk across the entirety of the kind of workforce. And really reduces the potential for a discrimination on the part of employers because it separates your benefits from your employers. So you're actually requesting your leave from the state government administration, not from your employer. And protections can be put in place to make sure that your employer can't retaliate against you for taking leave. In the second option, we actually see this existing particularly in New York State. There are some reasons I can go into later why New York chose this model. But this is a hybrid model where employers are allowed to opt out of the state option and provide private options either through a private insurance company or through self-funding. This is giving employers choice in how they administer their paid leave. And in some cases, that may mean that their paid leave benefits can be more generous. But it does require a lot more robust regulatory mechanisms. I know some states have moved towards this direction, hoping that it would simplify things, but it actually makes it more complicated because you have to have two entirely separate regulatory models. You have to have the administrative model for the state option, and then a regulatory model for the people that take private options. So it does add administrative complexity over an exclusive state fund. It also means that you have to kind of have a little bit more confusion for the employees because they don't necessarily know where their benefits are coming from. And it may mean the potential for discrimination if an employee has to go to a private insurer or their employer themselves to receive their paid leave benefits. But again, we have many, many state models to look at for examples, and we could talk more about those later. Next slide. And finally, the funding sources for the states. So when we talk about all these different models, where is the money coming from? As I mentioned earlier, the vast majority of states have chosen payroll contributions to fund their paid family and medical leave program. Most are shared employee and employer, much like Social Security. Some are employee only. Many states have chosen that for the paid family leave option, while the TDI, if they had an existing TDI program, that might have been shared between the employee and employer, but then the paid family leave portion that was tacked on was employee only. That's just an option that some states have chosen. And then, as I said, the employer-only option is something that's unique to DC. It's an option for states, but we can talk about why it's complicated. Private market coverage, so people would pay premiums, either the employer or the employer, or a split would pay the premium to a private provider. You could fund the paid leave program through general revenues. This is a little bit more unstable. It doesn't really tie the benefit to where the source is coming from. So it's a little more confusing for people to see, but it is an option. And you could also, as I mentioned earlier, have an employer-sponsored coverage such as self-insurance, where an employer pays kind of takes the risk onto themselves of paying for paid family leave. And there are challenges with that, as mentioned earlier, with people potentially perceiving a risk of discrimination or retaliation for taking time off. But there are circumstances where states have allowed employers to self-insure. And that is all for me with paid family leave. I'm going to turn it over to Marc.
Thank you very much. Good afternoon, everyone. I'm delighted to be here with all of you in virtual Michigan, and I'm happy to report that I had no travel-related issues getting here, so I'm ready to jump right in. I appreciate the opportunity to present today, and I applaud the National Academy of Social Insurance and Caring Across Generations for sponsoring this important event. Can I have the next slide? This is actually just an overview of what I hope to accomplish today, and describing some of the long-term care financing challenges and solutions, and describing the universal family care solution. Next slide, please. So the case for action. Of the adult population reaching age 65, roughly half will have significant LTSS needs, and LTSS is long-term services and supports. For those who need to pay for care, the average cost can exceed $200,000. Yet we Americans both unfair to pay for our own care to see if actually needed. The capacity of family caregivers who for the bulk of individuals needing LTSS is diminishing. Private long-term care insurance is now out of the financial reach of most middle-income Americans, and the largest public payer of costs, the Medicaid program, which comprises a sizable and growing share of state Medicaid budgets, is under severe stress. This is only worsening, of course, in light of the increasing health demands brought about by COVID-19, as well as the economic upheaval of the pandemic. So the need for solutions to address an inadequately financed and underfunded LTSS system is critical. One of the reasons we're talking to a variety of states is because, in fact, states end up being the ones left holding the bag. So I mentioned that LTSS represents a growing proportion of state Medicaid budgets, upwards of 35 to 40%. And as that growth increases, there's a chance and a likelihood that it will crowd out other policy priorities. Second, families are having to reduce their labor force participation to care for their loved ones, and this actually hinders economic growth. And finally, there's quite a bit, even in the context of family caregiving and payments for long-term care, there's quite a bit of unmet need, which drive up medical costs and quality of life for people who have disabilities. Next slide. There we go. Perhaps the most important point to note is that LTSS is an insurable risk. What you basically have is a small probability of a potential catastrophic event occurring for a relatively small group, roughly 15% of the population. And it's very difficult to predict in advance when one might become dependent on another person for assistance with basic activities of daily living. For that, and for many good reasons, it makes a lot of sense to try to move the system away from a social safety net or welfare-based approach toward an insurance basis. And some of the more prominent reasons for doing so are listed. Some of the major benefits of a social insurance program for LTSS are that number one, they allow families to keep loved ones at home, of course, enable seniors to age in place. They support people with disabilities living in the community. They bolster the care economy by infusing new funding that can help to spur growth. And they enable workers who are family caregivers to either work full-time or pursue careers. Medicaid, one of the big reasons why there's growing interest across a number of states has to do with the need to reduce Medicaid on Medicaid and somewhat surprisingly, there's another reason why a universal social insurance program for LTSS is important. It could actually provide a significant boost to the private insurance industry as public awareness about long-term services and supports increases. And with the establishment of a social insurance program, private insurers could offer wraparound or top-up coverage, much like they do in the Medicare market with Medigap coverage. Next slide. So what are some of the core decision points that states have to decide as they put forward some of these programs? There are a number of important ones. For example, not surprisingly, there are a lot of issues around who is the eligible population, who should be able to participate in these programs. Is it, for example, people who are already having long-term service and supports needs? Should it include people under age 65? Should people be required to pay in for a certain amount of time? Such decisions have implications for specific program designs, options for how the program is to be financed, and public support for the program. Not easy issues. In the report that we did, our study group had to grapple with all of them and basically laid out the issues involved with each. There's also the timing and duration of coverage. Should a program have front-end coverage where benefits begin to be paid as soon as someone becomes disabled, but only last for a limited time? For example, like in Washington State. Or should it be back-end catastrophic, where family and private sources would take care of needs up front, but if the needs got too great, then you'd have a public benefit or comprehensive coverage. Finally, there's program financing issues to consider. Some of the key issues are like, what is the source that makes the most sense for a state? Recognizing that there are trade-offs associated with various financing sources. You could imagine a program keying off of existing federal social insurance programs or existing state social insurance programs, or even bringing in new financing sources. And it's very important to make a decision up front, like what are the criteria by which we make judgments about the financing sources? Very, very important to think about it. And here are some of the issues that one would want to consider. There's the size of the tax base, political sustainability, fiscal sustainability, and so on. Next slide, please. So universal family care. Here the idea is an integrated insurance system for family care supports. The policy vision of universal family care is really a new integrated social insurance program to support families in coping with the risk of needing to provide or receive care across the lifespan, to which everyone contributes and from which everyone is eligible to benefit. Now, the idea is that, we may experience a variety of care needs at once, sandwich caregivers, for example, who need to care for children as well as older adults, or we may experience them over the course of a lifetime. And these care needs are not, they're not felt in isolation or experienced in isolation. And we need a streamlined system of supports for people to be able to manage these care needs, either happening at the same time or sequentially across the lifespan. Next slide, please. So imagine imagine a single pool of dollars to which you contribute and from which you can draw upon when care needs arise over your lifetime. The idea of this is that it reduces bureaucratic complexity for families, and it basically provides a one-stop shop and single access point to address family care needs. Again, the rationale for such a universal approach is that the needs or risks being insured against are normal parts of social or biological life for everyone, not just those with low income. Hence, its universality. Could I have the next? And of course, there are synergies in addressing all of these together, administrative efficiencies and so on. Could I have the next slide? Some of the advantages, some of these pillars are fairly straightforward, and I've covered those. There's a little bit more meat on the bone here, but the basic notion is that work is the foundation, a pillar of universal family care. There's a single access point, okay, that supports needs as they change. It's flexible and portable. So it covers people across different jobs, including 1099 income, where we're a lot more of the labor force is actually engaging right now. And it also leads to investments in the care workforce, something that is particularly important. This tends to be a workforce that has been underfunded, and like me, I'm sure you've all seen the myriad of articles about our frontline workers. These are the workers, many of whom that we're talking about right now, that are grossly underfunded. Next slide, please. So what are some of the advantages of an integrated and universal approach? Well, the advantages of an integrated and universal approach are listed here in the slide. But the basic idea is that this new holistic and comprehensive social insurance approach is designed to support families in coping with all of these different risks. And it's the idea is to create an affordable, integrated system of care to really replace the patchwork that we have right now. Next slide. In our report, we actually engaged an actuarial firm to provide some initial financing estimates. And here you'll note, you can see here what we've been able to model. These are ballpark estimates at the national level, so they're not Michigan specific. But here's what I want to point out. Based on these preliminary estimates and the different types of taxes, the contribution level required to fund benefits could, in most program designs, be around 1.5% of earnings for most workers, with a higher rate on individuals earning above $200,000 and couples $250,000. If contributions were structured as a flat rate on all earnings, the rate would be about 2%. Now, with this contribution structure, a family with a median household income of around $61,000 would pay an annual contribution of about $950. But if this family needs a home health aide where the median annual cost is around $50,000, and if they need childcare, the average annual cost for children under 4 is nearly $10,000. The reason I bring up those numbers is sometimes you see a number like 1.5%, 2%. You don't know, is this a big number or a small number? What I want to emphasize is this demonstrates the financial power of leveraging an approach based on risk pooling and insurance. Finally, the last slide. Okay, so in this slide, we just list a few of the primary benefits of such a program. I'm not going to read through them. The key point I would really like to leave you with is that leaving the status quo care infrastructure intact, that is, the doing nothing option, could actually be the most economically and socially costly option available to policymakers. Our current arrangements leave workers and their families largely to fend for themselves when care needs arise. This has pernicious effects on child development, adult labor force participation, family economic security, health, and quality of life. So I leave you with this question. If not now, when?
Okay, thank you very much to Alexandra and Marc for those presentations. We are going to now move on to a more open discussion portion of the webinar. So I understand that the slides that Marc and Alexandra presented will be posted on the website. So if you'd like to reference those. So I'd like to now welcome our Michigan panelists who are going to bring some much needed hands-on local expertise to this conversation that I think is really critical. So today with us, we have Sherry Boyd, Henrietta Ivey, Oriana Powell, and Dr. Alexis Travis. So I'm gonna let you each invite you each to introduce yourselves, talk about your experience, and as a conversation starter, I want to ask you to share what you think is the most important challenge in the current care landscape from your perspective, from where you're sitting in Michigan, that you think needs to be addressed.
I'll start then, since you named me first. I'm Sherry Boyd. I'm the director at the ARC Michigan, which is a public policy advocacy organization, and we advocate primarily for folks with developmental disabilities who are receiving services in the public mental health system. So primarily, we have folks who are getting long-term supports and services from their local mental health agencies. As for a number of years, before that, I worked in what's called Michigan Alliance for Families, which is a special education navigation statewide system for parents who have kids in special education. Before that, I was a local director, and then I did direct care and social work at a local community mental health agency a number of years ago. So coming full circle, I think some of the one of the barriers in Michigan is just the patchwork of services that was alluded to in the conversation that was presented earlier, but also the silos that occur in the service system. You know, aging is one silo and pre-K is another silo. So we're all over the map in terms of how you get services, and it makes it really confusing for people who need the services and for families who need the services. But those are the barriers that I see currently, and the funding mechanism, of course, is a problem. Primarily, at least for folks with adult who have developmental abilities and they're adults, their long-term care support services are primarily funded by Medicaid, as everyone knows. So, thank you.
All right, Henrietta, do you wanna take it away?
Good afternoon, everybody. My name is Henrietta Ivey. I am a home care specialist, home care advocate, and I am also the founder of Black Women in Home Care Detroit. And I have been involved in home care for over 20 years. I got started as a home care provider when my grandmother got ill. And with that, it trailblazed me into understanding the great need of the workers that do this work. When it comes to taking care of a family member unexpectedly, it takes time away from your family, and it also takes away from your income that you earning. Because a lot of times when you are doing home care, not a lot of time, but most all the time when you're a home care worker, if you're not specifically attached to a hospital where you're doing it from the standpoint of being paid through an employer where you can actually make money, you're not going to be paid substantial amounts of money. So for me, when I was propelled into taking care of my grandmother, I was actually going to school to become a teacher. And then I kind of branched off into the medical field, looking at other options. Home care actually was not one of them because I didn't think that, I didn't have any knowledge about what it was and what it involved up until, again, when I started taking care of my grandmother. So that propelled me, trailblazed me into fighting for this workforce, because what I found in the 20 years that I've worked in this workforce, nothing has moved. Nothing has moved financially for us. Nothing has moved educational wise for us, and we're still sitting in some of the same seats that we have been sitting in since that time. We are in 2020, and what scared me the most for this workforce was when we got into the pandemic, and I got many calls from workers, home care workers, direct care workers, caregivers, who was uh, involved in taking care of other people, family members, through adult foster care and through private care. And what happened was there was nothing on the books for PPE, raises, or anything for home care workers. And this was coming, and I checked on that because I wanted to find out. I said, well, let me see what's going on. Maybe there's something the state of Michigan can do, because a lot of these workers are contracted through the state of Michigan if they're not actually working directly with the adult foster care home. And even if they're working in the adult foster care home, what I found was the state of Michigan is paying those owners to pay their workers. So that money is still coming from the state. Nothing was on the books for them for protection. Nothing was on the books for them to get raises. This was something we had to really bring aware to our government in order for them to get what they did get. It wasn't there originally. So for me, in doing this work, my mission is to rectify this workforce and make it become a workforce and not a contract job or not a babysitting position, because with those titles come little. When you hear someone calling home care workers and direct care worker babysitters, and when you hear that they're not real workers, these workers like myself is out here taking care of family members. We're not just cooking and cleaning and making a sandwich. We're way beyond that now. Maybe back early on, maybe 30, 40 years ago, we just went in and did some of the simplest work, which was okay because it's still needed to help, to be that noble, to help people who can't do some of the simplest things. So it's not snide upon, but when we are not looked upon as workers, and we are part of a healthcare system, but we're not part of that system where we can be, when we can go and get raises, and when we can be, we could take care of ourselves as far as making enough money where we can contribute to our lifestyles, where we don't have to go to a Medicaid program. Unfortunately, there are people who, older people who are on Medicaid and Medicare, and we take care of those people, but we find ourselves being on Medicaid too, and getting those same substances that the people we take care of. So what I'm trying to do, what I'm working to do, when I created Black Women Home Care, I created that organization to bring light to the workers in that field. And what I'm not saying is that there are not other ethnicities in this. What I'm saying is this workforce is predominantly ran and operated with Black women in this work. So when I decided to bring light through that, I wanted it to open up the floodgate gate and understanding who does this work, because there are so many of us do it, but Black women carry this on their back, and we are not being paid, and we're not being respected, and we're not being dignified. So I am working hard. And when I became part of the Caring Majority, and when I became part of Empire Alliance, who did a lot of research, a lot of studies on this workforce, and this is what we found. So yes, I'm working alongside with some wonderful, wonderful people. Claire Liz, Sarah Slocum, Kathy Grant, Christine Odom, Vernette Mahone. It just, the list goes on and on and on, of all of us who are putting our time and effort in to make this workforce recognizable, so we can be a part of, taking care of ourselves. So we can be a part of being able to put money away so when we can pay for our own personal care. And so, it's a lot that has went into this project. And I am just really happy to be part of it. And I'm happy to be one of the voices that can be able to stand up for these workers in this workforce. And like I promised my home care workers, we will get it done. We will get the recognition. We will get what we deserve. And we will rise up in a system that has proven study after study that without home care workers, child care workers, these essential workers, which are not considered essential up until this moment of pandemic, we are essential. Henry Ford did a study, I believe it was in 2010, on Fox 2, that indicated that they're finding that when they have people to come in through the emergency rooms and people going into rehab, having a home care worker in the home with people who's trying to recover is essential, and it brought down the percentage of people returning back for additional care because they went home with nobody there, particularly elderly people, to care for them, and they had to go back after having surgery or rehab to try to care for themselves, and found themselves relapsing and having to come back for additional care. And so they indicated that. And so with that study alone, amongst many other studies, we definitely are trailblazing and trying to get this workforce recognized, and just make it better for the workers who does the work.
All right, thank you. I want to echo that there are a number of studies that I out there, many studies out there that I've seen that have shown the effectiveness of home health post hospitalization. Okay, I'd like to give Oriana Powell a chance to introduce herself. Thank you, Henrietta.
You're welcome.
Thank you so much, Yulya, and thank you so much for everyone that's on the call, but particularly in this moment, Henrietta. I know you just did such a beautiful job of really breaking down the problem in direct home care, and I'm just so thankful to be able to follow up because that is just so much, but it's so true, and I'm so happy to see you. Hello. But my name is Oriana Powell. I am the childcare movement organizer at Mothering Justice, which is a Michigan-based nonprofit focused on economic justice for women of color, mothers of color, and caregivers of color. I'm so thankful to be in this conversation today. You all just really don't understand. I've been working with the Michigan Care Majority for the last few years, and I've always been excited to see when in Michigan universal family care would come to full circle and be including childcare. So again, thank you, Alexandra, for the great introduction as to why childcare is just as important and needs to be introduced in relationship to the other parts of this piece as well. So thank y'all so much. Again, my own history is I've been a childcare worker for multiple years. It was something I did in addition to 2 other jobs. Once upon a time, I was working in childcare and working 2 other jobs. And when I got pregnant, I realized that the center that I worked at, I couldn't afford to actually bring my child there. So when I would deliver my baby, I really wouldn't be able to afford that child care there. And so shortly after that, I left that position, still working the other 2 jobs. And I found, basically I found the Michigan Care Majority very soon after that. When I delivered my baby is when I was introduced to this work. And I've been following and in awe of everyone involved ever since then. I've also done home care work, so I absolutely just admire and respect all the work of home care workers and Henrietta, and I'm so proud of you and the work that you're doing, because I know it's very necessary. But the reason why, one of the things that I think is one of the bigger issues for childcare is similar to what Henrietta had to say, is that this work has always been ignored. It's always been made to be invisible. It's always been disrespected, and I think that along with the fact that it's always been gendered as women's work, right? It's women's labor. That has been is given this country and many other countries the excuse to completely divest from it and not put any investment into the infrastructure that's necessary for what it looks like to actually take care of our children, take care of our elders. And so for me, one of the things that we're fighting at Mothering Justice and that we're building is an infrastructure around our informal care providers, those friend, family, and neighbors cares. I think those are the folks that do so much of the invisible work, but this country has decided don't deserve any pay, any training, any support whatsoever. And so at Mothering Justice, we are focused on our mothers of color, our caregivers of color, but we're also focused on the folks that actually build the infrastructure for them to succeed and to survive. And so we call those people our other mothers. And so across Michigan, we've been building with folks who do all the work that no one really mentions and no one thinks about, but helps families, specifically parents, to care for children. So folks who are doing some of that informal work that looks like, picking kids up from school or watching kids, especially during the pandemic, there is a lot of informal work that's happening because no matter what money came down federally for schools or what money came down for childcare, we've lost a lot of centers in Michigan. There are a lot of centers, both licensed and in-home care, that were unable to open their doors, didn't have the financing, didn't have the support to do that. And so, as always, we lend and depend on our family, our friends, those who are there to support us, but don't seek out, right? Out of obligation, out of duty, out of love, don't seek out or see or identify themselves as caregivers. And I think that those folks are always been the pillar of what really builds the care infrastructure. And that's what we really want to raise in Michigan and continue to do that work in relationship to the care majority and caring across. For us, it's the folks who are completely invisible, don't even recognize themselves as caregivers, but allow for our economy to continue to move forward because they're being completely uninvested in. And so the economy can move with or without supporting them. But this work is going to continue to happen, whether policies are created or not. And I think that's just what this country is betting on. And we want to bring them something else. Like, you have to start acknowledging these people, these grandmothers, these aunts, these mothers who do all of this work without any recognition or any support whatsoever.
All right, thank you. Thank you, Oriana. So to our final panelist, Alexis Travis, do you want to go ahead and introduce yourself?
Yeah, good afternoon, everyone. I'm Dr. Alexis Travis. I lead the Aging and Adult Services Agency with the Michigan Department of Health and Human Services. I also am the co-chair of the Direct Care Worker Advisory Committee to the Department of Health and Human Services, and I serve on that alongside the amazing Dr. Claire Wells, who many of you have mentioned already on this call. And I also sit on the Governor's Developmental Disability Council. And I think it's also important to share kind of my personal perspective on these issues, as I grew up in a long-term care facility, which was managed and owned by my family. And so I provided direct care myself. Not many people know that. So bring a different perspective as an administrator, but I also immediately became aware of these issues because numerous advocates came to visit our senior leadership, myself, Director Gordon, and Dr. Janae Caldoun, and under their leadership, we've been able to make great strides over the last several months with the establishment of the Direct Care Worker Advisory Committee. But also in the last couple of weeks, we've released our new state plan on aging. And so we have many priorities right now. Many of the priorities relate closely to the conversation we're having today. The first being to improve, the access and reach of information and awareness of aging network services to older adults and their caregivers. The second one being to promote and prioritize resources to promote social interaction and connectedness, including expanding access to technology and transportation. The third one, increasing the number of well-trained, qualified, and supportive multicultural direct care workers through collaboration and elevating the workforce, improving retention, promoting its collective value, and supporting opportunities to increase wages. And so that's something the department really supports. And then finally, leveraging programs, services, and resources to ensure that older adults have the opportunity to make decisions that enable them to age in place. Most of the time when older adults polled, we receive over a 90% response rate that indicates that older adults would prefer to remain in the community setting of their choice. And so as much as possible, we want to be able to honor that. And we know in Michigan specifically, we have a rapidly aging population. In fact, those over 85 are the fastest growing segment of our population. And those over the age of 60 now outnumber those 0 to 17 years. So what that means for us is we need to be prepared. We need to be thinking about long-term services and supports and how we're going to be able to continue to fund that. Right now, only 7% of individuals are investing in long-term supports and service and insurance. And so that means many people are unprepared. And we see that in our office where people wait until later on and they have more complex needs, they're in a place of crisis. And so I think the conversation that we're having today is going to be really important because we need to think about how we get people thinking about those things ahead and can also make sure that people are prepared and then reduce costs associated with the long-term care system. Thanks.
Okay, thanks to you all. So I'd like to encourage kind of a robust conversation. So you know, if folks want to react to each other or say anything in addition, please feel free. I'll pose sort of something that is very clear to me from what you have all said, as well as kind of the world that I live in, which is a very remote research world, is that family caregivers and direct care professionals working together is key to addressing this growing need for services. Neither group is really going to be able to manage this on, you know, as a silo. And so how do you see an integrated universal framework such as being proposed today kind of alter how people receive care services, and thinking in particular about the different groups that you all are familiar with? So older individuals, people with disabilities, families with young children, in the Michigan context.
This is Sherry. I think that one of the key points probably would be to figure out a universal funding mechanism. I mean, again, I had mentioned earlier that people with disabilities primarily get their long-term supports and services on a daily basis from Medicaid dollars, and you have to qualify for those, and there's never enough of them. So, you know, if there was a way to look at the proposed payroll taxes and maybe some state dollars, that would certainly help the cause, I think, in terms of having a universal funding system. I think probably the aging side of things has a little bit more diversified funding. I think one of the other barriers is a lot of this stuff is done through waivers at the federal level, so that would have, you know, that would have to be addressed with the federal government in Michigan.
And for me, I think for home care and direct care workers, I think what would be a significant start would for us to be able to be listed as a healthcare worker is to change the right to work. Like I think I feel personally there was some clause in there that that prevented us from moving forward once they put right to work in, because at one point we had over 50,000 or more home care workers in the state of Michigan who were working and being paid through the state of Michigan because, you know, their family members qualified for that. And these workers were able to have some stability through that. But once right to work kicked in, is something in there that, from I told, is something in there that's prevented us from moving forward from even being considered a home care worker. Like we go like a different route. But let me be clear, because there are a lot of people who take care of family members because they have to, and it becomes a job. So with that being said, there has to be some type of removal of the right to work, or a new policy created for this workforce, so we are able to be considered for all the benefits that we desire and we earn through the course of our work. Like for instance, I have had conversations with home care workers and direct care workers, particularly home care workers in private pay, who did well, and they love the work they do. They love it. They like taking care of their patients. And what happens when your patient dies? What happens when that patient is no longer in a position where we can take care of them. They have to go through like a 24-hour care. And so we lose those workers. As workers, we lose our patient, which means we lose money. And we don't have anything, no compensation for that. So I think we need to have new policy where compensation is included in this particular um, workforce, and this, so we are able to take care of ourselves in case we lose work. When we lose people, we lose work, and so that keep us at a lower standard because we don't have any compensation or recourse that we can go get until we get build up our clientele again. So I think that we just need new policy and somehow work that right to work out of Michigan for all workers, but particularly for home care.
Yeah, I agree. I feel like for child specifically, I think something universal would completely change the experience of folks who are actually getting child care support. Like was said before, there's absolutely no guarantee. There's no social responsibility for anyone to support a parent or a caregiver who is in need of child care right now, unless you are completely impoverished, right? Like you might have some access to the subsidy. All of that is completely on the family. It is completely on the family to figure out. It is a private responsibility. And if the door is open to a universal program where folks could open up access to getting some type of support, that would completely change the experience of many families with young children. I think right now, there's so many kids in Michigan right now who are outside of both licensed programs and outside of programs that, or even like federal programs like Head Start, all of these different programs, who are being cared for, again, by this invisible workforce of folks who just do it because it has to get done. And there is no consideration for the burden that those people take on. There's no consideration for the taxes, that they have to sustain because they're at home helping another parent get to work, right? Like they're at home with the child, or those kids are going without proper care in some circumstances. And so I think just opening up the opportunity for every family, no matter income or even with income limitations and some type of structure, it would completely change the experience of actually trying to get childcare in Michigan.
Yeah, I would agree with that as well. And I think many people now are caught in that sandwich generation where they're providing care for younger family members, school-age family members, or early childhood. And then they're also providing care for older adults, either in the same household or a different household. And so I think, the more that we can have supports universally available at both ends of the spectrum would be great. But I also think that, as I mentioned earlier, many people don't prepare for older age. They don't prepare for family members aging as well. And so they again get in this situation where they're caught in the Medicaid spend down, and they basically have to diminish and deplete all of their resources so that they can receive the care that they need. So I think that taking that into account is really important, and this will be a way to avoid that. So if we think about the broader picture, we want people to be more socially and economically stable. We want families to be able to share that intergenerational wealth, but they can't do that if they're required to spend everything they've got to be able to cover of the care that they need. In terms of more broadly, I think that many people providing care to older adults are also still either in the workforce or forced to leave the workforce. So this is, an amount out there, $300,000 it could cost somebody in terms of the lost earnings and also retirement funds, just to be able to take care of a family member. And so we definitely don't want that to happen. So being able to cover the cost of those lost wages is going to be essential for people, again, to maintain their economic status moving forward. So I think more broadly, it's going to have an impact on the economy. And then as well as growing the direct care workforce, paid direct care workers is going to be essential as well to keep up with that demand. And we released a policy brief late last year, and we had looked at some of the issues affecting direct care workers, and we found that low wages, inadequate access to training because training was so expensive, value of the job, all of those things. And when you look at the healthcare system now, everything is value-based. You got to be able to establish and demonstrate the value of a service that people are receiving. And without professionalization, without certification and some kind of quality standard that really solidifies and demonstrates what direct care workers do, because it's very, very complex and very highly skilled job that they're performing, then I don't think that we're going to be able to get to that place where people understand they've got to make that investment. So I support also what Henrietta was talking about earlier under that piece, and I think it's going to make a very big difference in the aging world.
So something I hear you all saying is that while increasing wages for care professionals is really important and should be a first order challenge, it's not sufficient, and there needs to be, so it's not solely wages that are a challenge for this workforce. It's also job stability, it's also credentialing, it's also access to benefits, it's also working with other and being recognized by other healthcare providers. That's very important. Which I think is a really important conversation, especially in any sort of design of a broader system. So I want to welcome if you guys have any other comments, if you have on other concerns or challenges that need, and then with a particular focus maybe now, clearly the pandemic hopefully will not last forever, but it's certainly changed the way that care is delivered, and how family caregivers, direct care professionals, and sort of the healthcare system work. So, do you see can you talk a little bit about how you see those challenges, whether or not you think they're permanent, if things have shifted in a way, towards a new equilibrium, and sort of how you see things going forward?
Yeah, so I'll go first on this one. I think what we've seen in the pandemic is that it has amplified or magnified the issues that were there prior to COVID. So prior to COVID, we knew that people didn't know where to go to get services. They didn't understand the systems that they have to work through. And so we've seen that amplified. We also had a direct care workforce crisis. It's gotten worse. At one point, people could make more by staying at home than they could from going to work because of unemployment benefits. And so, and they've struggled with things like childcare during this period of time. They've struggled with things like their own long-term services and supports for loved ones as well. And so all of those things have happened. And then under normal circumstances, caregivers are that they're less likely to take care of their own care needs and defer to the people that they provide care for, right? And so now, in the middle of a pandemic, is the time when people most need to take care of their own care and haven't been able to. And so I think all of those things are things that we've seen before this time, but we know even more so now, people need to have access to options so that they are able to make the right choices for them and for their loved ones at this time. I would also say that as we continue to think about long-term supports and services, I mentioned options, and options are going to be so critical because each person is dealing with their own unique array of circumstances, and we need to have things that meet people where they're at. And so just like we say, we have to be person-centered in the delivery of long-term services and supports, we have to also be person-centered when we're developing these solutions for direct care workers as well.
Let me say this too. What I found during this pandemic is in this workforce is there are a lot of resilient workers who continued to push on even when they knew that there was nothing coming their way. They continue to work and care of their client without question. And that right there, this pandemic shined the light on the resilience of this workforce, that these workers are going to work because it's and what we found is it's not something they're doing because they don't have nothing better to do. They love the work that they do. We love taking care of people. This is a noble, not only a noble position, but it's so needed because when you grow an attachment to people you take care of, um, that means something to that. That's trustworthy there. That's love there. There's a combinedness between the families and that worker. And in this pandemic, we found that a lot of these workers are going to continue to go to work and put themselves at risk. So I think with that being said, this is one of the things, why, I stay in it and fight for so hard, because these workers are resilient. They're going to work. They're going to take care of people no matter what. And that's a skill and an art that everybody cannot do. Let me be clear on that. Taking care of another person's loved one is not something, it's not easy. It's not, it doesn't come with because you're undereducated. It comes with love, concern, and you have to be educated because you're not, again, just making a sandwich. You're taking vitals. You're doing all these medical needs to this family that is not recognized by these workers. So the resilience of these workers really came through during this pandemic.
I wanted to briefly say I would echo the same issues that Alexis pointed out in the supports for folks with developmental disabilities. Certainly during the pandemic, the crisis for to find workers is worse. And we have been lucky enough here to get increased wages for folks who are working with people with developmental disabilities. And we hope to make it permanent. But still, there's not enough people to do the work, and people continue to need supports on a daily basis. So
I just want to kind of follow up on or just to stay in agreement with what Henrietta was saying. I think at the top of not only in the middle of the quarantine for us, or right in the middle of the summer, we found that there were so many childcare centers who were actually struggling to do the people all the things they were still taking, not only the kids that they had before, but some were making space for school age children who had no summer schools to go to, who had no other summer programs to go to. And they were doing everything that they could under restrictions to make sure that those families still could get up and go to work every day. Those essential workers were still going to work. The other thing that I wanted to say around what I think Dr. Travis was saying was the options, right? I think for childcare specifically, the idea of a universal system has to kind of like really be what folks said before, is like it has to really be centered around the family and the child themselves. I think a lot of times, since the beginning of like the quality rating system, we understand that what quality looks like is not what a parent or a family chooses, right? And I've talked to so many childcare center owners or workers who have said that the whole process of licensing and getting things together feels very punitive to them, right? They don't see themselves in the work. They don't see themselves in all of the criteria and the eligibility and all that. It makes it really impossible for them to do that. And so I think it's not only is it going to change the system for parents and family members, but it's going to completely change the system for providers and folks who look at this as an opportunity for entrepreneurship. And that's what Black women and women of color and immigrant women are doing. A lot of women desperately depend on what childcare looks like to build up themselves and their own families. And I think having the opportunity to really consider what personal choice looks like when it comes to just culturally informed folks, right? Having folks consider what a family needs and what a family desires versus what has been deemed by like from a very clinical aspect of what quality looks like, what quality care looks like, doesn't consider families, doesn't consider folks' personal choice. And so I think anything that we reimagine has to start there. What does this parent feel like, or what does this family feel like works for them and their child best? So I'd be excited to reimagine and think through what that looks like, to completely change the quality rating system, so that folks feel like they were actually considered, the work that they do, the safety that they commit to for their children. Because these are, not childcare workers are very similar to direct care workers. They're an extension of family for a lot of folks, right? Like there are people, customers, or depending on their childcare provider, who have no family, who don't have other support, and those people open their arms to these families and in the community that they serve, and they absolutely build relationship that is viable for both parties. And I think they have the children's best interest at heart. And there are so many pieces of like paper and pieces like what it looks like, like licensing and regulatory, all these things that don't consider what these people have to go through to make sure that they have a center that meets the needs of the family and the communities that they serve.
Okay. Thank you to everybody for sharing those experiences and those reflections. I want to open it up to I'm going to bring Alexandra and Marc back on, and then open it up to some audience questions so we can keep the conversation going and bring in the audience. So the first question we have, what about the flexibility or, so this is kind of coming back to a more technical structure, like you were looking at it, about the flexibility or portability of a benefit across states? How can we address this issue? How can we address individuals or families maybe not living in the same state, not living in the state forever, the opportunity to provide caregiving remotely, questions like that.
Thanks. That's a very good question. I'll answer that, and then I want to reference some work that I think relates directly to some of the issues that Oriana and Henrietta and Alice and Sherry brought up in a minute. So those are potentially challenging issues. Part of it is really depends on the extent to which a benefit, the structure of a benefit. So you'll note that when I was talking about different decision points that states have to make. So if you imagine a cash benefit, then it's maybe not so critical. If you've paid into this, if you've been paying into this system and you qualify for benefits, then in the sense of if it's a cash benefit, it doesn't matter where you are. But those are, for example, some of the issues around portability and so on are issues that Washington State is having to deal with. And I imagine that as more states get involved with these programs, they're going to come out differently on whether you have to live there a certain amount of time, whether you have to actually be in the state at the time of eligibility. If I relate directly to LTSS, for example, so you're going to want to make sure that there's some mechanism to determine that somebody has met the eligibility trigger. I did want to mention for the seminar that we just completed at the LTSS Center with one of our colleagues, an economist, Christian Weller, Robin Stone, myself, and Beth Almeida, a study that looking at what would happen if you actually pay a living wage to direct care workers. What would be some of the impacts? And we looked at it in terms of one of the things, the key thing that we found is that the benefits associated with that pay for the actual cost. I mean, there are fewer staffing shortages, lower turnover, higher productivity, improved quality care. We used economic analysis to show the increased consumer spending. And actually, as you all well know, more than 20% of direct care workers are actually receiving public assistance payments because of the poor pay. So there'd be a reduction in government expenditures. So interested in that, I would look at it because I think it provides, all too often we say, this is going to cost X dollars. And we only look at that side of the coin. We don't look at the other side of the coin, which is it refers not just to the care worker themselves, which is critically important, but there are societal benefits that often get ignored just because they're difficult. So,
thanks, Marc. Okay, another question from the audience. What mechanisms could be used to make sure that any new benefits include fair wages and benefits for care workers? So how do we structure these systems to ensure that workers are taken into account?
One, just for a state's program, that written right into the program is that reimbursement will be paid to agencies that pay a living wage. I mean, it's just very simple. This is the people that will be eligible if it's a reimbursement model, for example. Take that one. Reimbursement model, you say contracting guidelines all the time, providers of services. And a simple thing like that could go a very long way for toward moving the system toward being living wage. I'm sure there are other examples. I'll let others speak to
that point about portability. A lot of that goes down to how the state designs the program. So the development phase is really cool. And people kind of advocating for their needs in the writing of the law is really important. And you've seen this with paid family leave, right? The way who showed up and who at the table when decisions were being made about how the policies were written at the state impacted how the benefits were designed, how it was paid for, all those things. And so when you look at that's like a really critical phase for getting those things in place. I think Marc's point about writing it into law about a living wage is really important. When one of the struggles with DC for the paid leave program was that because the employers were the payer of the benefit, a lot of you have to be employed in DC. But that may not actually be true if you design an LE payroll. It could be that you live in DC, but you might work in Maryland or Virginia. So all of that stuff goes into the design from the get-go, and it's something that you kind of have to massage as folks are writing and advocating for the original policy.
We have one more question for the audience, and I want to encourage people in the audience to keep the questions coming. So what is the average wage for direct care workers and child care workers? I guess in Michigan specifically, but then also sort of how does it vary? Does it vary nationally?
It does vary nationally for childcare workers, but on average, most childcare workers are seeing $9 an hour. So a lot of places it's less than that. And if you are actually working with a family that does get state subsidy, and you're a family caregiver, right? Let's imagine like grandma or someone else that's a family or friend is taking care of that child. Those folks are receiving something that looks more like $2 an hour. And is not only the amount that folks are making, but the reimbursement scheduling completely affects how much a person makes when that child is enrolled. And so it causes a lot of issue with folks having to not only pay up and take care of whether it's buying food or all the things that childcare centers do prior to seeing their money reimbursed. Oftentimes that they're still coming out of pocket without seeing any of that money reimbursed from the state. You're muted, Henrietta.
Oh, wait, you're still muted.
So what I found with home care, there's not like a reimbursement unless you are you actually own a home care center. Like if you actually are, hello, can you hear me?
We can hear you.
Okay, I'm sorry. If you actually own a center, like if you are a person who has a home care business, a lot of the workers work through that, and they are paid according to the national average for that worker. So that worker is still making somewhere between $8.50 to maybe $10. It depends on if you're working for a private home care agency or if you're working for a home care agency chain. The chains tend to pay their home care direct care workers a little bit more, right around the $9.50 to $10.60 an hour. But for us, we're not seeing that reimbursement. So we're it is still kind of on that national level. And for home care workers, the pay rate is different too, according to the counties you live in. Like in Wayne County, I found home care workers make a whole lot less than Oakland and Macomb County. So those pay rates shift according to those guidelines, according to those counties. And again, those mentions of who you're working for and what agencies are getting the reimbursements on time, and that can actually pay their worker a little bit more, but it's still not at a livable level.
Yeah, I would also add, I mean, it varies across agencies and across programs. In Michigan, the Behavioral Health Administration has made some progress in increasing pay for direct support professionals in recent years, and they have had incremental increases to their pay. We've also seen, as somebody mentioned earlier, that there was a $2 per hour increase related to the coronavirus, and that's something that actually prior to COVID, folks felt that a $2 per hour increase would be appropriate under normal circumstances. And so I know there's a big push for maintaining that increase, but I think the average right now for direct care workers is about $10.70. And so definitely, it's a choice. People often talk about, well, it's choice whether you want to go and work in a fast food place or you want to provide direct care. I will say that direct care workers that I know and know of take great pride in the work that they do. And so I always, it almost makes me cringe when people say, well, it's, a choice between working in fast food restaurant or providing direct care, because the impact of the role is very different. And so if we could just, address the pay issues to align with that, I think that would be great. And it's definitely something the department here at MDHHS supports.
So let me interject a little bit on that too, because it shouldn't, and when you have here, and myself too, hear these questions of making a decision to go from one low wage job to another low wage job, and we happen to decide which one is better based upon a dollar more, a few more, I'm just not comfortable with having workers in this having to decide whether they're going to work fast food or whether they're going to do home care, particularly when we know home care is a position where those workers are needed. They are needed. Fast food is not to say that that's not a job, because I personally fight for anybody who get out there and work. We should all have a livable wage. Let me be clear. I'm not implying that you did, Dr. Travis, but I'm just saying in retrospect, when we have people out here working, period, we all should be making a livable wage. Yes, granted, if some of us go to school and we are lucky enough to do that, myself and a lot of us on this panel who is lucky enough to go to school and increase our educational endeavors and find jobs that pay, according to those skills, that's a blessing. But we're talking about people who may get that opportunity, who have other barriers that has blocked them in their lifetime from reaching these goals. One of them being having to stop your life and take care of a loved one. And so those things need to be, factored in when we talk about what are the barriers, what has and what is preventing these workers from achieving higher education so they can get higher wages. Because we all know, education and the wages based on education. We just know that. Like if a person get up and do an honest day work, they need to make an honest, livable pay. Like I don't think a home care worker or a fast food worker should make less than $15 an hour. As a matter of fact, to be honest about it, because both those workforces require people to deal with other people issues when they're coming through that drive-through, or to go and deal with a person's mother who's not only sick but has other issues going on, and we dealing with that every day. $15 an hour is still not enough. So we're going to look at it from a perspective of how are we going to fix this system. Let's start with the wages. Let's start there. Let's start and say if you're working, pay anybody in this country need to understand that we need to not pay these low wages and find reasons not to take care of people. If the country is not going to pay a livable wage, they need to be responsible for whatever else needs to be, because life depends on what you make. And $15 an hour is okay money, but it's still at the point where if I'm making $600 a week and I'm single, I'm okay. It's just me. I'm not feeding nobody but me. But if we're talking about a family, a mother, father, or sometimes a single father or single mother who's making $15 an hour, trying to pay rent, buy food, want to send their child to college, can't because they're hindered, because the fact matter is they're working their, excuse my French, their asses off, but still not making the money to put away to take care or save for their child, then this country needs to be responsible for that. Stop playing with people's money. And I'm going to say this, and I guess right now I'm getting zealous. We need to stop playing with the people in this country when it comes to working. Work is work. Any work is honest work. And that honest work needs, and if I'm working, if I'm flipping at the car, flipping burgers, and I got to go make your sandwich and put up with your attitude, pay me. I got to go home and deal with the fact I only brought home a $300 check, and I have to put up with all of that mess that somebody throw it on me that day. And this country tend to think that, and these corporations who make billions of dollars, billions, and they refuse to pay these people at least call it $20 an hour. That's what it takes for a person to live in this country. You need to be making at least $18 to $20 an hour if you're talking about trying to sustain life and put something away. 15 is just a knock at the door, but to really live and do and take care of yourself and raise children and families. And I feel like all of it. When you go to school and you spend 6-7 years in school, become a doctor, teacher, nurse, you come pay me for that, because I'm building a skill that requires me to use my skill to take care of what person ever I'm taking care of, whether I'm a doctor providing medical or I'm a home care worker providing care. Look, those skills come, and with those skills needs to be paid. So let's just be real honest. If we want people to live in this country and live well, pay them. Pay the honest day work. If I flip a burger, pay me. If I take care of a patient, pay me. If I'm taking care of your child, pay me. Because I'm not just sitting there stupid. Let's be clear. None of these positions I mentioned are sitting there because they don't know any better. It requires skill to do it. So $15 an hour, and these, $10 an hour for at max food care work. That's not money. That's a 16-year-old. We are not 16-year-old. We're full-grown people with full-grown responsibilities.
All right, thank you on that. That's an excellent way to end this. We are at around 3:30. I want to pass it over to Bill to take us out.
Thank you, Yulya. And on behalf of the National Academy of Social Insurance, I want to thank all of you, Alexandra and Marc, who were part of the study panel that produced our report that we're trying to then disseminate throughout the country in partnership with Caring Across Generations and Support Foundation. Yulya, thank you as a moderator. And I really want to thank Oriana, Henrietta, Sherry, exactly the right perspective we have to have. Those of us who deal in policy, it's so easy for us to forget that the end result of all this are people who need more than we're probably put it in perfect. So we like to translate our policy work. What does it mean to people? And especially on this issue, all of us at some point in life are caregivers, care recipients, or more likely both. So talk about a universal risk that just cries out for a national social insurance solution. This is it. So thanks for making this come alive for all of us. For those of you who participated, thank you. You're going to get an email following this webinar with a link to a brief survey. Please take the time to fill it out. We rely on feedback to look at further efforts to address this pressing issue. We're going to continue to provide opportunities to exchange ideas in the universal family care space. Our next webinar will be focusing on another state, Illinois. My hope is all the states compete for who can do the best job in this area. Wouldn't that be great if that was a competition that governors and legislators said, yeah, Michigan wants better than Illinois. I think that'd be great. But when all is said and done, this has to lead to a national solution. The states be the laboratories, but we're a national community, and we have to look at it as a nation. We're in very difficult times. Thank you to all of you for making time for this, especially to our panelists and participants. Let's hope that things get before they get worse. The evidence doesn't appear to be that, but please, all of you, stay safe, stay healthy, and thank you again for giving of your time and your insights on this critical issue. Thank you.
Thank you. Have a great day, everybody.
Thank
Bye-bye.
Bye-bye.
Yeah.